Our speaker today is Dr. Nicholas Restrepo. He's the Vice President of Medical Affairs for Winchester Medical Center, a board-certified urologist. Prior to assuming his current role as Vice President of Medical Affairs, Dr. Restrepo had been in private practice with the Urology Clinic of Winchester and a member of the Winchester Medical Center attending medical staff since 1995. He has served as chairman of Winchester Medical Center's Division of Urology, chair of the Department of Surgery, and a member of the Medical Staff Executive Committee. Dr. Restrepo has provided leadership to the Medical Staff Affairs Department on a variety of technology and communication initiatives, quality reviews, and new physician orientation. Dr. Restrepo earned his undergraduate degree from Catholic University of America and his medical degree from the University of Virginia. He completed his internship and residency at Pennsylvania State University College of Medicine in Hershey, Pennsylvania. Fellow Rotarians and guests, Dr. Restrepo.
Thank you very much. To get organized here. I guess, John, can you see the slide okay? You just give me a thumbs up and I'll know we're good.
We're good.
All right, fantastic. Well, listen, thank you very much. It's always a pleasure to speak before the Rotary. I've had the opportunity once or twice over when you were able to meet in person, and I believe I gave a prior pandemic update in a prior portion of the pandemic. Before I could go too far, I'd like to thank the Rotary for all that you've done for this community. As some of you know, I've been involved with the Northern Shenandoah Valley Substance Abuse Coalition since its inception, and without a doubt, the most important partner we have in the community has been the Rotary, and the work that the Rotarians have done to help support all the social determinants of health of the patients and really our family members in the community that are struggling with various issues surrounding substance use disorder has been invaluable. And you are a shining light in the community, and you're a shining light that we speak of outside the community whenever we talk about the work of the coalition. So I can't start without thanking you enough. Let's spend a little bit of time sharing with you kind of the current reality of where we are today with COVID. It's impossible right now to give an all things COVID update because we'd be here for multiple hours. I focus the majority of my work on the hospital-based care. When the pandemic first started, we set up a command center a couple of years ago, and we divided it in really two sections. One of everything that happens within our hospitals, everything that happens outside our hospitals. Dr. Fight primarily is the guy in charge of everything outside the hospitals, and I've been leading the group for the 6 hospitals and the care we provide within the walls of the building. So my talk today will be heavily biased towards the inpatient hospital world. This is actually a slide of Dr. Fight's, appropriately enough. You're here right now with Omicron, you know, it's twice as contagious, but it's only half as lethal. And the problem is it's so contagious that the number of people that are getting it, the denominator is so huge that the impact on hospitals, hospital admissions, ICUs, mortality is tremendous, as you'll see here shortly. So yes, for the average person who's healthy, particularly if they've been boosted with their vaccine, it's not a big deal, okay? However, there are a lot of people that don't meet those categories. There are a lot of people with underlying comorbidities that make them a higher risk for problems. A lot of people who either opted out of vaccines or failed to get boosted who are having a lot more problems. And so the two figures here in the top part is, it's a way of explaining what's called an R value. And an R value in epidemiology is if you have a viral infection, how many people do you give it to? So what's the exponential growth look like for that one? And so a low R value means it's, 1 gives it to 2 kind of thing. The representation here at the top is what we've been working through most of the pandemic. 1 person typically will give it to 3. And if you see if 4% of those folks are hospitalized, if that's the hospitalization rate, after 4 cycles of passing it along, in the end of the day, you have 8,100 people that get the disease, and 4% of that's 324. Omicron's represented at the bottom. The R value approaches 6. It's actually a little higher than 6. So only half of them end up in the hospital, half of the prior amount, so 2%. So you can see with 4 cycles of Omicron, you go to 130,000 cases roughly, and a whole host of people ending up in the hospital. And so rather than 324 hospitalized, you get 2,600. And so that's why, despite the fact that, yes, it's twice as contagious, but half as lethal, with that exponential growth, the impact on the healthcare system of the United States, the Commonwealth of Virginia, and your Shenandoah Valley is tremendous. This is looking at hospitalizations in Virginia since the beginning of the pandemic. And you think back to the spring of 2020 when we had our first surge, and then we've had another big surge, the significant surge in the state last January. We have exceeded that significantly. So there are far more people hospitalized now in Virginia than there have been throughout any other phase of the pandemic. So the impact on hospital care is the worst we've been since the start of this run. If you look, this is from this morning, looking at the state of Virginia, Winchester Medical Center, we've unfortunately been in the top 1 or 2 for about 6 weeks, along with Carilion. And this is all of the Carilion system, and this is just Winchester Medical Center. But we've been kind of sitting in the 1-2 spot for about 4 weeks. And then the past 2 weeks, we've seen an increase in other places. And we've been bumped out by larger hospitals like Inova Fairfax and VCU. They are on to the trajectory that the president mentioned earlier about Apollo. They are in the throes of Apollo. Inova Fairfax on January 4th had 64, 65 patients. I can't remember the exact number. 3 days later, they had threefold that number. And so the trajectory there is much worse than ours. We started earlier and peaked well before any of these other places. And so just wanted to put it in context that 132 people is a tremendous burden for a hospital our size. This is looking at who's in the ICU. What we found with this Omicron surge is that with time, initially our patients were mostly on regular medical surgical ward beds. With time, we've seen a shift to a lot higher concentration of these folks ending up in the ICU from primarily, although not exclusively, their underlying medical problems getting significantly worse. So they come in, they've got COVID, they have some respiratory issues, they have some complicated medical history, but there's exacerbation of the underlying medical issues that escalate them to the ICU. So we have, at this particular snapshot in time, 23 individuals in the ICU when this data was submitted. You notice Inova Fairfax is still down here. They a week ago had 5. And so they're on a little bit of a laggard curve where we saw that switch a few weeks ago. As they've gone up in number, they're seeing that switch as well, and they'll continue to climb up this listing, which is something that we get every day. This is looking at Valley Health, and again, the curves look familiar. They somewhat mirror the state curves, give or take a week or two when they actually may occur. This is from the beginning of the pandemic, and this is every person in a hospital during the course of 24 hours counts as one. So this is heads in beds, and it's a data point that I just want to make sure it's clarity around. This means that if Mr. Jones is in the bed at 10 in the morning and gets discharged home, and then Mrs. Smith comes in at 1 p.m., that counts twice, okay? And so I just want to be very clear about that. That's why these numbers are significantly higher, but this is how many people touch our beds and all kinds of beds, emergency room and inpatient beds during the course of 24 hours. The initial pandemic surge that we had back in the spring of 2020 was 40. If you recall, that paralyzed the health system. We were unable to do essentially any elective surgeries. Most all elective care was shut down. All PPE was diverted to that. We were very fortunate to have a robust testing platform. So we were able to kind of do a lot more testing than other hospitals in the state of Virginia, which at that point was very important because that helped you preserve supplies where you have to treat somebody with COVID until you know they don't have COVID. But because we were able to do that in-house and weren't dependent on external labs that took 5 days, we managed to make it through that first storm better than most places. Then we went last winter, January 4th through 6th, we peaked at 163. Marked difference, still a significant burden on the team. A lot of, it's a physically taxing thing, a lot of emotional trauma, but we had the supplies we needed to be able to do this. We had the process of care down, and we were able to maintain our other work, because what we found is with each one of these surges, anything you cut back on or kind of pump the brakes on results in a delay of those same people presenting with a worsened condition. So somebody, for instance, needs a cardiac catheterization, and you say, well, we don't have any place to do it today because we don't have the space. In the next 2 or 3 weeks, they needed that cardiac catheterization. They may end up having a heart attack. They may end up coming to the emergency room due to chest pain and having to have an emergency procedure. So we're trying desperately to keep things going to meet all the other needs of the community. Right now, with as bad as it is, the under roughly 40% of our patients have COVID. The other 60% are people who are here for other medical needs that they have. And that's even with us having suspended anything that's not essential in our current state. And I'll touch base on that more. We went through the summer, went up the spring rather, 69. The fall, we hit 177 and we were coming back down. And then boom, we went back up to 273. And that was 2 days ago was the 273. We're around the 260s here the past couple of days. So if you look here, this is the right-hand side of that curve, just to kind of highlight it. Back in December 1st, we had 93 individuals, and I guess 273, 258, 253 the past few days. So we're hopeful and very much closely watching this, that we're on our way back down, okay? But this is, I tell people often that I grew up as a fan of the now Washington football team, and so I can convince myself of all sorts of things. And I'm convincing myself that we're hopefully at that peak and coming back down. But there's some data to support that. There's some data to refute that. This is looking at just people admitted to the hospital. So this takes out the emergency room. And again, huge impact, 200 people. And this is for all Valley Health hospitals, with about 3/4 or so of these, as you'll see, at Winchester Medical Center. This is this morning at 7:40, 167 people in our beds at the collection of hospitals here. 11 of them on the ventilator, 2 people waiting their test results. One of the things in that state report that I didn't show you is, if you look at those other hospitals, they'll have 30 and 40 people waiting those test results. But fortunately, we've got, as I mentioned earlier, a very robust process where we can get tests done in a pretty quick turnaround. Of the 167, 122 of these are just at Winchester Medical Center. Our only ICU capacity within Valley Health is at Winchester Medical Center. So all the ICU patients, all the ventilated patients, are at Winchester Medical Center. This 45 number is interesting because if you think back, we got paralyzed at 40 when this whole thing started. And that was 40 people at Winchester Medical Center, because the prior platform was, we'll bring everybody to the central place. We have all the resources here. We'll care for them here. What happened is, as the pandemic went along, we realized that was not going to be a sustainable solution. And we had to be able to get our other facilities to the point where they could care for these patients as well, and create processes of care where, using our electronic health record, we're able to monitor every patient in the system. And if they're deteriorating, we're able to reach out to the folks caring for them and say, hey, we need to take a closer look at this, and also transport people up here as needed should their conditions warrant. So the fact that 45 people are cared for right now outside of Winchester Medical Center is why we're still able to do some of the procedural work we're doing. Because if you put these other 45 people here and centralize it all in one place, we would have to be in a state where we completely shut everything down. So the value of the system and the value of the other entities increasing their capability around what they're able to care for and pushing their capacity, and is a collaborative care model that has served the region quite well. This is how we look at the command center structure. We do this on a daily basis. I put this more than anything on here so you can look at the issues that drive how we care for patients. So we look at space as one issue. You know, do you have a physical place to put the person? Where are you relative to staffing? And one of the challenges we have currently with Omicron that's different than prior runs of COVID is the number of staff we have that are getting COVID. Fortunately, we're early adopters of a vaccine requirement, and our employees are getting minimally sick. They got a head cold for 2 or 3 days, and they're coming back at 5 days. But even then, they're not here to care for the patients, and we're unable to properly staff in some areas. So we're having to activate other sources for staffing, and that's where you start moving into this more contingency phase approach. And then you have supplies, and supplies during this pandemic, you know, everybody knows about PPE, everybody knows about, you know, lab equipment and testing reagents and things like that. But for instance, right now we have 2 unusual and very crippling shortages nationally. And one is something as simple as potassium. So you need potassium for heart surgery to stop the heart when you're going to operate on the heart. It's part of what's called cardioplegia, which is what you put in the heart to be able to operate. There is a national shortage of potassium right now. So we're scrambling to find potassium in cardioplegia to be able to continue heart surgeries. There is a national shortage on blood supply, which I'll talk to more specifically here in a minute. But that's another thing that we're looking at on a multiple time a day basis. So the number of supply chain issues are diverse and still remain impactful. And then you look at how you're caring. Are you caring for people in non-traditional places with non-traditional staff? So as you go from left to right on this, and you go from green to yellow to orange to red to black, this is where you're looking at what the government has is 3 different categories of care. They have conventional, they have contingency, which we've broken into 3 phases. They have it as 1, and crisis. And you saw perhaps in the news yesterday that Mary Washington down in Fredericksburg went to crisis level of care yesterday. And Centera has been there in some of their facilities. And that's when you announce publicly that we are not providing the standard of care. We are unable to. They've gone, some of those facilities are 1 to 12 nursing ratios. A normal hospital with a high acuity like ours is typically about 1 to 5 on a med surg floor. And 1 to 12 is just hard to comprehend how you do that. So what they have to do is then they bring in non-clinical staff or inactive clinical staff to be a helping hand to that individual caring for that patient, so you can take your ratios up higher and higher. And so there are hospitals within the state of Virginia that have gone all the way to the right on this. We are not there currently. 2 days ago, had you had me talk, I would have told you it wouldn't surprise me at all if next week we were there. With this little bump down we've seen, we're very hopeful that that's not going to be the situation in this area. I put this in here because so many of you are employers or business leaders, and there's a lot of confusion about returning to work. And so I just pulled this is our employee health type stuff. But the fact that for people who are boosted, fully vaccinated, or unvaccinated, if they're asymptomatic, you can see it's 5 days from the test they can return. Okay, and repeat testing is not part of this process. The CDC, unfortunately, as they've done in many areas, has confused this. And so there's one place where they say repeat testing if possible, but then they don't tell you what to do with the testing. But the fundamental point here is, as you look at your own policies, one of the strains on the system is the use of the testing system of care. And as you return workers back to the workplace, it's really currently all based on time and symptoms. So it's by and large, for most people, it's 5 days, and their symptoms have to either be significantly improving and they have to have no fever for 24 hours. And then they can come back to work. Still, we're seeing many employers in the regions and educational leaders in the region requiring testing to return. It adds nothing to the equation. And those guidelines got sunset about 2 or 3 months ago. And so I put this in here more than anything to share some of the newer guidelines and our employee health process that we use. The other thing is that we're using home testing as well. And so a symptomatic person, so if you're having symptoms and you test with a home test kit, they're in general about 95% accurate if they're positive, okay? So if they're positive, they're very believable. And what we're doing now with our employees is saying, okay, test yourself. If it's positive, it's positive. We don't need to drag you in and do a PCR. If it's negative and you have symptoms, then you need to go ahead and get a PCR done. So that's helped improve the flow of patients, and also the availability of these tests has become a little bit of a challenge. And one of the things you'll see is that we have a process where we'll be getting them out in the community here in the next, hopefully, several weeks. This kind of just more than anything is to put in perspective that, you know, type blood O has been on critical shortage for about 1 or 2 months, where we have a dashboard that actually follows in real time our blood supply. And we get blood out of 2 regions. We get it out of the Inova Blood Bank, and we get it from the American Red Cross. And O has been in very limited supply for quite some time. 2 days ago, they added blood type A and blood type B. So by and large, pretty much all blood types are now on critical shortage. And the meaning of that is that when we have somebody that comes in for a big cancer surgery or a big heart surgery, we have to know their blood type, and then do we have blood that day so that that surgery is safe to do? And it's a complicated real-time daily decision-making process looking at that we have a group of people working through. Platelets, so what helps your blood stop from bleeding, critically low throughout the United States. We were very fortunate last week. We actually borrowed some from West Virginia universities. We couldn't get them from anywhere else, and they had some platelets that were going to expire, and we needed them, and they said, we'll give them to you rather than letting them expire. So we were able to use some platelets from WVU last week. The emergency release process that has always existed, where the medical director of the Red Cross, you can call, 2 weeks ago, well, actually today, we can call them and say, hey, we've got this patient who needs this heart surgery. and they're this blood type, can you give us 2 units out of your reserve so that we can proceed? And that typically the answer is yes. They have suspended that process nationally starting January 17th. So they're removing the medical release. We're doing a lot around this. There's going to be a lot more work coming forward, and hopefully you'll see in the community relative to blood donations that we're really going to be pushing forward to try increasing the blood supply. And as you can see, it's a problem throughout the country. The care team, just in terms of know what you're dealing with, as you see the rising patient population, the decreasing available care providers. Monday, we were in a bad place. We had 434 people out on quarantine. Yesterday, I made this slide yesterday. 297 yesterday, we're down to 260 some odd today. And so that seems to be getting a little bit better, but it's impactful to the team nonetheless. We have been in a state where we've not been doing non-essential elective surgery that requires a bed in the hospital post-operatively. We've been that way since January 3rd. We initially announced it was going to go till January 17th. In the next day or so, we'll be likely announcing that we'll extend that a little bit further, so that we can have a little bit of buffer, and also so patients realize that, hey, I'm not going to be off from work then, and rather than get canceled the day beforehand. We're moving to a couple other places. This 5F unit actually opened yesterday. It's part of the med-surg area at Winchester Medical Center, 15 beds that we opened yesterday to accommodate some more patients, to be able to have less patients boarding in our emergency rooms. There hasn't been a day in a month and a half that we haven't had patients boarding in the emergency room. There hasn't been a day in the past month and a half where we haven't had ICU patients, at least one, boarding in a hospital other than Winchester Medical Center. And as a result of that, we're likely going to expand our ICU beyond 48 beds here in the next few days. And that we do by pulling in some of the anesthesia team. So that would imply you'll have less surgeries. And so those things all need to marry up. And so there's potential that'll be happening here in the next few days. A few days ago, we started operationalizing the ability to use our surgery center, which is a facility that has the ability to all be negative pressure. So you can flip the whole building negative pressure, and you can put about 40 COVID patients in there. So it would be a ward style area. We have not made a decision to do that. We're meeting again here in about an hour. This is one of those things where 2 days ago, I would have told you we'll probably be doing it next week. Right now, I'm very prayerful that that number is coming back down and we're not going to have to do this. Relative to testing, one of the things I wanted to point out is down here on the bottom is that HRSA, a federal agency, gave us 200,000 or committed to give us 200,000 home test kits to distribute to the community for free. It has to be done through our rural health clinics. The only one we have in Winchester and Frederick County is at our Rutherford Crossing primary care office. These shipments are starting to trickle in. There's a little bit of disconnect between the federal government and reality. And so we're waiting to see when they actually get here. They seem to think they've shipped, but nobody's able to confirm that. But we're very hopeful that this is on the way and that we'll be able to provide a significant bolus of tests into the community so there's more availability. And that'll be available when that does happen. It'll be available primarily through our primary care clinics. We're also trying to partner with some community partners, including law enforcement and first responder agencies, to help with the distribution. Technically, it's supposed to be through the clinic, but once we get it going, we might kind of put the technical aspect aside. Our outpatient platform, we're about 200% above our normal levels for seeing folks that have symptoms like this for COVID. We canceled a lot of appointments for chronic medical conditions to create more capacity for primary care appointments to help people stay out of the emergency rooms. The emergency room is, the person in the waiting room in the emergency room is the most at-risk person because they haven't been evaluated yet. And we have very sick people in our ERs. And so if you're not super sick, we're trying to really create availability through urgent cares and primary care practices to get you access to care in a setting that's appropriate for your medical needs and still is able to maintain some availability to the members of the community that really need that emergency room level of care. Just a real couple quick bullets. You've seen some of this in the news sources. There's a couple different treatments that are out there that are very helpful to help us. Monoclonal antibodies, if you start them, it's an injection therapy, a couple different ways of injecting it. If you start them in the first 5 days, you basically cut the rate of hospitalization at least in half. So we take very ill patients with a lot of chronic underlying medical conditions and try getting them there. It was really good until Omicron came along. We were doing 150 of these 200 of these in a couple different infusion clinics we set up. Omicron, unfortunately, there's only one that works for it, and it's a sotrovimab. And so we likely are going to be shifting to just offering this one because the prevalence of Omicron is so high in this community that to put resources towards giving something that's unlikely to help isn't really a good place to be. Sadly, this is all a scarce resource. Unlike the vaccines where the federal government invested in multiple vaccines, most of which never came to market, that same approach wasn't taken to these therapeutics. And so we're waiting on the supply chain to catch up with the demand. It's something that helps very much keep sick people from getting sicker when they get COVID and ending up in the hospital. The oral agents, there's two. Paxlovid is the Pfizer product. Molnupiravir is the Merck product. The Pfizer one's probably a little bit better. The Merck one's more available. They're still in limited supply. It's kind of the same principle as Tamiflu and things that you may have taken in the past for the flu. It's a pill that helps markedly decrease your symptoms if you start it early after diagnosis. The state of Virginia is dependent upon the federal government for the allocation of this, and then the state allocates it throughout the Commonwealth. In general, today, the Pfizer product is available through Walgreens in Virginia. 2 days ago, the only Walgreens that had it was in Woodstock. We had patients from here driving down to Woodstock. And then the Merck product is available through Valley Pharmacy. They both have excellent data on decreasing the adverse effects of COVID, and hopefully will help lead us forward in this pandemic, and much like Tamiflu did with the influenza virus. So you may be asking how folks can help. Vaccines, to continue to promote vaccination. And so to talk to the Rotary about vaccines is a pretty easy lift, okay? Your website has these two links on there, both of which are excellent in terms of your response as an international organization to COVID, and your response and kind of reminders about how you take all that you've learned about vaccines and apply it to COVID. I added a couple of things for your information, just as we've been fighting this vaccine fight, and the importance of boosters is enormous right now. Is take a look at what is the driver of why people say yes to a vaccine. So this takes vaccine hesitant people relative to COVID and said, okay, what makes them, what messaging worked best for them? It was a marketing study. And the three on the left have been very important. And I think I've personally kicked the tires on all these. I'll touch base on protecting the children in a second. The financial cost of COVID, it's devastating for a family to get COVID. And so here you have a shot that's essentially free, or you can run the risk of ending up with an enormous series of medical bills and compromised ability to work afterwards. And that has been very effective for some people. And then the fear of missing out. A fair number of people, like as places require vaccines to go to restaurants, to theaters, to travel, they don't want to give that up. And so it's actually a powerful message for some people that were vaccine hesitant. And so we had gone a lot of, show them the facts, show them little stick figures and all the badness that happens without it. As I've talked to people in kind of my normal life, this left-hand side of this graphic is very helpful. The children, 1 in 500 kids in the United States, as of June 30th, had been orphaned as a result of COVID. It's a staggering number. And I put this up here because the way they define orphaned is, losing primary or secondary caregivers, and the little boxes here kind of tell you how they checked out on this. But fundamentally, when you talk to a COVID vaccine resistant person and you say, you know what, you're compromising your potential for being here, and your grandkids might not get to know you like you'd like to. You may not have that influence on them like you'd like to. It resonates with people. And so given the history of the Rotary of vaccines, I wanted to make sure I touch base on that. And different ethnicities are impacted to varying degrees here at the bottom. But it's extremely tragic what's happened to these kids by losing their parents, their grandparents, and folks that provided over their head, met all their needs, and provided their day care. So another way you can help is promoting responsible behaviors. The masking deal is interesting. People have these passionate beliefs around masking, and let me tell you something. I don't love walking around with a mask, and as a surgeon, I grew up living in a mask. So I'm fairly accommodated to them. There's plenty of evidence to suggest that a mask decreases the danger. And what it really does primarily is decrease the danger of you giving it to somebody else. And so the more you can wear it and the more you can model that and encourage that, the better off we're going to be, because we got to do everything we can to work our way out of the current situation we're in. I think sharing what you've heard today about the hospital is struggling, okay? And our healthcare workers are absolutely exhausted. They're emotionally fried, they're physically fried. They're dealing with a challenging group of patients. 80 some odd % of our patients are unvaccinated and have strong beliefs around healthcare. And they're more than happy to share them, as are their family members. And it's a very difficult time. And whatever you can do in your personal life and your professional life to support a nurse, support a respiratory therapist, or pharmacist, people that have been doing this now for 2 years without stop, I can't emphasize enough the importance of that. Donating blood, I think Rotarians, and one of your former Rotarians has quite a history of being blood donors, and so I don't need to emphasize that. And then in your professional life or in your community, following evidence-based guidelines to return to work. There's not a test-based return system anymore, and that includes for both schools and work. And we're working with the community partners. Dr. Feit's leading that work to try making sure that that's widely adopted. So again, I'm happy to take any questions and clarify anything I may have said.
Nick, there are a couple questions already in the chat box, like how long do the boosters last? And do you think we'll need to boost again? I can answer that one.
Yeah, it's unknown, unknown the impact of that. Again, I'm better off telling you what lottery number to play than I am telling you what's going to happen with boosters. I know both major pharmaceuticals in the U.S. Are working on an Omicron specific one and plan to have some clinical trial data out in the early spring. I don't know how that'll impact things. So fundamentally, the answer is we don't know, and we'll have to wait and see whether or not we're going to be getting boosted again.
All right. Dan wants to know, where are we with convalescent plasma? Does it work on the current variant? Does it work on the current variant?
Convalescent plasma got retired a while ago. It got retired many months ago, and so it ended up not being something that had quite the boost that some of the other therapeutics we've gone to have, and so that's something that's been set aside.
Okay. Patty wants to know, will this recorded presentation be available? I'm sure it will be. We can send this video out, but Dr. Nick, can you share your slide deck with us?
Yeah, I'd be happy to.
Okay.
I'll email it to one of you, and you can just.
Great. That would be great. And actually, Kim had the same question. And then Nellie says, thank you, Dr. Restrepo. Great information. Jamie wants to know, what about the correlation between kids who get COVID and type 1 diabetes?
Yeah, I'm probably not the right guy to answer that, quite frankly. I'm a urologist. I got to at least sometimes stay in my lane. I can help you get information surrounding that. One thing that I will tell you about that's interesting is that one of the things we're seeing that's slightly different, I may have mentioned this with this variant, is we're seeing a lot of exacerbation of underlying illnesses. So we're seeing people that come in that have been diabetic for 20 years, well controlled, and they come in and they are what's called diabetic ketoacidosis. They're horribly out of control for no real reason that can be identified. Then they come up COVID positive in the admissions process. And some of these ICU patients we're seeing have COVID. Okay, they're positive, but the real driver is their normal underlying disease that has been well managed for years has gone totally out of control. And so that I will tell you that relative to diabetes, but I would have to defer to others around the kids and their diabetes.
Okay. And a related question: is there information on the longevity of natural immunity or guidance around boosting in combination with natural immunity? Yeah,
so it's interesting. A lot of this is still anecdotal. I can tell you that as a parent of 5 kids, 2 of them have had COVID twice and they're vaccinated and boosted. One of them just got Omicron, who had Delta, was fully vaccinated. Got COVID, Delta, fully vaccinated, boosted, and just got Omicron with very minimal exposure. And so it's a normal, healthy kid. And so a lot of anecdotal evidence that natural immunity is just so good. And that the key to, I guess, his tale is the fact that he got minimally symptomatic the second time in particular. So it helps decrease, but it does not cut down on the ability to get it.
Gotcha. Libba wants to know, what about someone who got a severe reaction to the first booster? Any advice on the second booster?
Yeah, so that's a good one to talk through with the physician. Or it was a really good one to talk through when we had the vaccine clinic open at Apple Blossom Boggs. They saw all these reactions. Most people can safely get it. You can also switch vaccines. So they've made the protocol such that you can switch from one to the other, and there's slight component differences. So depending upon what the reaction is, you may be well suited by switching. If you're severely immunocompromised, and this is the case where you couldn't get the second one, there is one type of antibody that's only approved for severely immunocompromised people that gives you extraordinary protection for 6 months at a time. It's a 2-shot regimen in the muscles that is an option for somebody, for instance, getting cancer therapy that was either unable to get vaccinated or wasn't able to complete the vaccination course, or is on a cancer therapy that you think the vaccine didn't help the patient. So there is a newer available through the state of Virginia and available here at WMC for a very subgroup of people that would fit in that category.
Okay. And Cyril Barch, you may have to pronounce the first word, but what is your experience with patients demanding Plaquenil and Ivermectin?
Yeah, so we've had that. It's not only the patients, it's typically they come with a crowd. So it's typically the patient and the family wanting therapies that really aren't consistent with what's known to be beneficial. And we have stood our ground on that and not provided that in the hospitals that in the hospital settings that we care for patients. We've been threatened with litigation. We've managed to thus far not end up in the courtroom. We've had instances where Southern States product was removed from a patient's room by our nursing team, where it's a little box that says ivermectin, good for up to 1,500 pounds. Nice little horse running through the field and apple flavored, in case that's what you're after. So we've had to compensate some of that. And that's one of the challenges our staff's facing, is that, having the patient's loved one at the bedside is a tremendous benefit for the patient and for the staff 90% of the time. It's this other smaller population of folks that aren't as collaborative, don't want to wear our PPE when we ask them to, and that really make for a very difficult and challenging environment with a reasonable number of fairly antagonistic visitors. And this, to Cyril's point, this is one of the areas where it gets a little bit spicy, and our team's done a really good job of managing that.
So your response to ivermectin is nay. Any other questions? I think we've gotten all the ones in the, one more. Are there many children being hospitalized at Valley Health?
Yeah, we are, is a nuanced answer. Today, and prior to today, we are not hospitalizing kids that have COVID that have respiratory issues. So in the kids early on, GI symptoms was very common. Those kids we did hospitalize, and we'd have 1 or 2 at a time kind of thing. The current, the most recent wave where you get more of a respiratory thing, we're shipping those kids to children's hospitals because those kids may deteriorate and we don't have that level of care for that patient population. So we're transferring out a small number of children to either University of Virginia, to DC Children's, or Inova that do require hospitalization. We have transferred out a half dozen or so kids who have ended up in ICUs throughout the state of Virginia, throughout the Valley Health during the past couple months. 1 or 2 of which has gotten very, very ill. And even been on what's called ECMO, which is kind of a bypass product for bad lung issues. So those kids are not typically being hospitalized here. We're typically transferring those children. And that's our current situation with that.
You mentioned GI issues in children?
Yeah, so early on, it was a lot of GI symptoms. So kids would get a lot of either diarrhea or nausea and vomiting and things like that they get dehydrated and get sick from COVID. And those kids we do care for here.
Yeah. Okay. And then I see one other. Would the intramuscular treatment you described be useful for folks with Bell's palsy and Guillain-Barré and folks that can't get?
So it's a very specific set of guidelines, and I'd ask anybody interested in this to talk to their physician about it, and they can reach out to us if they need more information. It's not a vaccine. It's a monoclonal antibody, and so it's about a 6-month boost to your immune system by injecting a long-acting monoclonal antibody. And it's approved for a very specific subset of people. And some of them are severely immunocompromised individuals. And so you can't just give it to anybody, but there are criteria for it, and it is available. And we did a presentation yesterday to the Valley Health physicians, and so they should all, and I actually emailed out those slides, and they should have all that information in their inbox.
Okay, great. Thank you. Any other questions from the gallery? You can just unmute yourself now because we've gotten through the bulk of them. President John, did you want to close out the meeting? Because we certainly want to thank Dr. Nick for being here with us again. Hard to believe it's been a year, and yet the song remains the same. We're just singing it much louder now.
I'm going to actually ask one question, which I have to be the guy that asks the difficult question. We're past Omicron. Any signs or any rumors from WHO of another variant that is posing a threat at the level of or greater than Omicron that is starting to surface out there?
Yeah, there's always a variant, and there's other variants. Lambda was one that we all feared probably as much as Omicron or more. It started out in Peru and it was going to be really bad, and that didn't pan out. So they're frequently identifying variants, and there's none that I'm aware of causing any significant outbreaks in any pockets of the earth that I'm aware of currently. But one thing I've learned to say repetitively right through the entire pandemic is at this time.
Yeah.
At this time, I don't know of any. But there've been a few that we feared tremendously that never came to fruition. This one sadly did.
Yeah.
Need to carry a piece of wood around with you everywhere. So every time you say something like that.
All righty. Well, in spite of the fact that the topic was not exactly the most uplifting in the world, it is always a pleasure to have you with us.
Thanks for having me. And you guys take care, and I'll email you the PowerPoint here in just a few minutes.
All right, and I do promise that I will edit and upload this meeting this weekend, because I'm actually taking a 4-day weekend up to YouTube. So it will be available for the membership and the 0 subscribers we have to our current channel.
Well, thank yous are popping up in the chat box. So.
All right. Well, thank you guys very much. Thanks for what you do every day for the community.